Good evening, my dear friends and colleagues, and Eid Mubarak على الجميع إن شاء الله. Our topic today is post-streptococcal glomerulonephritis. This is our agenda. It is better to know that glomerular injury or glomerulonephritis can occur following any infections affecting our body. So the best term or the better term is infection-related glomerulonephritis. It is not only post-streptococcal, but it can follow any organism, as we are going to see now. Glomerulonephritis can occur following bacterial infections, and these are the most commonly causing bacterial infections. I am highlighting the most important one for us. Streptococci can cause post-infectious glomerulonephritis, which is our main topic today, followed by membranoproliferative. Staphylococci can cause IgA-dominant infection-related glomerulonephritis, which will be discussed in details in the next lecture and video, inshallah. E. coli can cause an IgA-dominant infection-related glomerulonephritis, and mycobacteria, of course, mycobacterium can cause membranoproliferative or immune complex-mediated glomerulonephritis, diffuse proliferative, and of course, following long-term infections, long-term mycobacterial infection, it can cause secondary amyloidosis. Also, glomerulonephritis can occur following viral infections, and this slide is very important, especially for the exams. Hepatitis A usually cause membranoproliferative glomerulonephritis. Hepatitis B commonly cause membranous nephropathy or membranous glomerulonephritis, followed by membranoproliferative, while hepatitis C most commonly cause membranoproliferative with or without cryoglobulins, followed by membranous glomerulonephritis. Also, hepatitis C infections can cause fibrillary glomerulonephritis and immunotactile. HIV also can cause commonly collapsing glomerulopathy, and can cause focal segmental glomerulosclerosis. Parvovirus can cause also collapsing glomerulopathy and focal segmental glomerulosclerosis. Also, glomerulonephritis can occur following parasitic infections, especially we are going to discuss malaria infections. Malaria infections by the Plasmodium organism can cause membranoproliferative, mesangioproliferative, membranous IgA, and minimally changed disease. Schistosoma, of course, can cause membranoproliferative glomerulonephritis, focal segmental, and long-term infections can cause secondary amyloidosis. Now we will discuss in details post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis is decreasing worldwide, but it remains a problem in developing countries. It decreased worldwide due to the early antibiotic administration, so it decreased dramatically, but it remains an important cause or medical condition, especially in older adults with comorbid conditions. Post-streptococcal glomerulonephritis is the most common cause of nephritic in children. Don't forget that is the most common cause of nephritic presentation in children in developing countries, and it can occur sporadically or in epidemics. The typical age is from 2 to 14 years of age, years of age, with a slight male predominance of 2 to 1. So it is the most common cause of nephritic in children. The risk of having post-streptococcal infections following infection with a nephrogenic strain is the average risk is 15%. So when the patient is infected by a nephrogenic strain, the risk to have glomerulonephritis following that streptococcal infection is around 15%. But it is important to know that this risk is much more higher in skin infections compared to throat infections. Skin infections by streptococcal organism has a 5-fold increased risk compared to throat infections. So don't forget that skin infections are more risky to develop later glomerulonephritis. What about the pathogenesis? Post-streptococcal glomerulonephritis is a prototype or a classic example of immune complex mediated glomerular injury. Immune complex mediated glomerular injury. And we have 3 immunological mechanisms for this immune complex deposition. The first one is passive entrapment of a circulating immune complex. There is circulating immune complex that will be deposited in the kidney, or in situ immune complex formation due to interaction with implanted bacterial antigens in the kidney, or due to immune complex formation with antigens in the kidney that results from molecular mimicry. So we have 3 mechanisms: circulating one, or in situ immune complex formation with a planted antigen, or antigen that results from molecular mimicry. All of them will cause complement activation following this immune complex deposition. There are many streptococcal antigens, but the most important for us are the nephrogenic antigens, which are involved in the pathogenesis of the glomerulonephritis following streptococcal infections. The most important two are we have 2 important nephrogenic streptococcal antigens, which are the nephritis-associated plasmin receptor. They are very important to know. Nephritis-associated plasmin receptor antigen. And the second one is the streptococcal pyrogenic exotoxin B. Again, nephritis-associated plasmin receptor and streptococcal pyrogenic exotoxin B, and it has a precursor. Another precursor is called zymogen precursor for this streptococcal pyrogenic exotoxin B. This antigen, which is the streptococcal pyrogenic exotoxin B, is the only antigen that have been demonstrated in the subepithelial humps or the electron dense deposit characteristic of post-streptococcal in the kidney itself. So it can be a question. So these are the 2 most important streptococcal antigens which are involved in the pathogenesis. This table illustrates the different mechanisms for glomerular injury following different infections. Of course, our topic is more concerned about the streptococcal infection. As we said, it can be circulating immune complex that will be trapped in the kidney, or in situ immune complex formation, or following molecular mimicry with antigens in the kidney. Staphylococci can cause glomerular injury by being a super antigen, by giving a super antigen that will bind to antigen presenting cells and activated T cells. So we'll discuss it in the next lecture. Also, viruses can cause direct infection, and the virus particle can be detected in the kidney itself, like with HIV and parvovirus. Also, viruses can cause direct renal cell injury, like what happened with hepatitis B virus infection, which will induce mesangial cell proliferation. And also, another mechanism can be through cryoglobulin production and deposition in the kidney, which is commonly caused by hepatitis C virus infection, as we know, of course. So this table is also important, illustrating the different mechanisms for the glomerular injury following different infections. Now we will talk about the clinical manifestations. And the clinical manifestations of post-streptococcal glomerulonephritis are different in children from adults. Children have presentations and adults have other manifestations. Children usually present typically with acute nephritic presentation, acute nephritis, including hematuria in virtually all patients, macroscopic hematuria in 30%, hypertension in 80%, and edema in 80 to 90%, and oliguria in around 30%. Typical nephritic presentation and nephrotic syndrome occur in only 2% of children, only 2%. This is in children. So in children, typical nephritic presentation. What about an adult? In adults, 20% can present by nephrotic syndrome. So in children, nephrotic can occur in 2%, while in adult, nephrotic can occur in 20%. And renal impairment in around 83%, and take care of that. And 43%, around 40% can have congestive heart failure. Congestive heart failure resulting from volume overload and oliguria. Rapidly progressive glomerular affection and rapidly progressive glomerulonephritis can occur in less than 1% of children and adults. So don't forget that children usually present by acute nephritic presentation, typical nephritic presentation, while adults can present by nephrotic syndrome in 20% and 40% with congestive heart failure. Also, most of the patients give a history of previous streptococcal infection. This is very important. This is very important in the diagnosis. Most of the patients give a history of previous streptococcal infections. And streptococcal cultures are positive in around 10 to 70% during epidemics and in 20% in sporadic cases. So don't rely much on cultures to diagnose patient with post-streptococcal because it might be negative in most of the cases. What are the common infections that will precede or come before the glomerulonephritis? We have either skin infections, impetigo, or throat infections, or pharyngitis. Impetigo or skin infections are usually occur within 2 to 4 weeks before the glomerular affection. 2 to 4 weeks, don't forget that. And pharyngitis usually occur 7 to 10 days before, can occur 7 to 10 days before the glomerular affection. So skin infections have a much more latent period before glomerular affections. However, skin infections usually predominate in the group A beta hemolytic, group A streptococcal epidemics. In epidemics, skin infections are much more common. What about the complement? Complement will be reduced, especially serum CH50, and of course the most important is C3. C3 will be decreased. C3 complement due to complement activation is depressed in more than 90% of patients. Very important. It is one of the differential diagnoses of decreased serum complement in nephrology. Decreased or consumed C3. C3 will be decreased in post-streptococcal glomerulonephritis, especially in the first week of the disease, and it will be normalized within 2 months. Within 2 months of disease resolution. And characteristically, C1 and C4 are normal. This is also very important. Complement 1 and complement 4 are normal. Cryoglobulins and rheumatoid factor and C1q can be positive in up to 1/3 of our patients. So don't forget that C3 is consumed or decreased and C4 is normal. Because the cultures, we don't rely too much on streptococcal cultures to confirm our diagnosis, and cultures can be negative in many patients. We can rely on antibody level, anti-streptolysin antibody levels to confirm this infection. The most widely used antibody is the anti-streptolysin O-titr. Very important, anti-streptolysin O-titr, which will be positive or will be high in more than 60% of patients. And also another antibody which we can measure is the anti-DNase B-titr. The second one is the anti-DNase B-titr, which will be elevated in around 73% of post-impetigo cases. So anti-streptolysin E-titr in more than 65% and anti-DNase titr in more than 70% of cases. We can use the more sensitive streptozyme panel which measures the anti-DNase, anti-hyaluronidase, anti-streptolysin O-titr, and anti-streptokinase antibodies, which will be positive in more than 80% of cases, so it is much more sensitive. While antibodies against nephritis-associated plasmin receptors and streptococcal exotoxin are much more sensitive and specific, but unfortunately they are not clinically available. So what's in our practice is the anti-streptolysin O-titr anti-DNase. Now we'll talk about the pathology. Renal biopsy, as we know, is not routinely indicated in post-streptococcal. It is not routinely indicated in such cases, but it can be required to confirm the diagnosis with atypical presentations, atypical findings, such as nephrotic presentations or decreased C3 for more than a month, for prolonged period. So a nephrotic presentation or decreased C3 for a longer duration, this or a patient with increased renal dysfunction or in adult patients, these are atypical features and which will need renal biopsy to confirm our diagnosis. What about the light microscopy findings? The typical presentation in light microscopy, of course, is diffuse proliferative. Diffuse proliferative. It is a prototype of diffuse proliferative presentation. Diffuse proliferative characterized by endocapillary hypercellularity, including monocyte infiltration and neutrophils, with some focal exudation can be found, and also small number of crescents and necrosis can be found, but small number in 50%. Small number, not a large areas. So the most important is diffuse proliferative pattern. And this is an example. As we see here, there is diffuse proliferation, and with many cells inside the capillary lumen, diffuse proliferation of the endocapillary cells and mesangial cells, of course, with monocyte and neutrophils infiltrations. What about the immune fluorescence? Immune fluorescence is characterized by dominant C3 staining. This is the most important. Dominant C3 staining, dominant C3 with different patterns. We have different patterns for immune fluorescence. We have starry sky pattern, and we have the garland pattern. Garland is in Arabic iklil, tag, iklil. And we have the mesangial pattern. In a starry sky pattern, like in Nugum, we have Nugum, we will see pictures now. It contains strong C3 and intense IgG, and it can have IgM in up to 50%. It is a common presentation. IgA and C1q are not features. and this is an important differentiating point from the IgA dominant related glomerulonephritis. So in starry sky, we have strong C3 and intense IgG. What about the garland pattern? Usually occur when there is numerous subepithelial deposits and heavy proteinuria. Starry sky can occur in acute and subacute disease, while garland can occur in active and later disease, later in the disease process. The mesangial pattern usually when there is clearance of the deposits, in subacute and chronic injury, we can find the mesangial affections, which will stay for the longest time, or it is the last one to be cleared, the deposition in the mesangial areas. So we have, don't forget, strong C3 staining with IgG and IgM. We have different patterns, starry sky and garland and mesangial. As we see here, this is the mesangial affection or the mesangial pattern, mainly in the mesangium. This is the starry sky, very illustrative, شبه النجوم. This is the garland pattern, like the الإكليل on the head. This is the garland pattern. What about the electron microscopy? When we, of course, we have the characteristic subepithelial humps, which are typical but not pathognomonic. It is not pathognomonic. It is important to know that subepithelial humps can occur with other conditions like C3 glomerulopathy and C3 glomerulonephritis and dense deposit disease. Subepithelial humps can occur with other conditions. This is the Bowman, this is the parietal, this is the podocytes, and this is the subepithelial deposits. What about the differential diagnosis? Patients, of course, patient with typical presentation, typical symptoms like having glomerular affection or hematuria and proteinuria with a previous skin or throat infections with raised anti-streptolysin O-tetra and consumed C3. Of course, the diagnosis is straightforward and it is very easy to diagnose patient as having post-streptococcal. But in some cases there might be some concern or some atypical presentations, or there is some doubt, especially in patients with persistent oliguria or persistent azotemia for more than 2 weeks, or hypocomplementemia for a longer duration, more than 1 month, or if there is no clear history of preceding infections. In such cases, renal biopsy is indicated to confirm our diagnosis. The renal biopsy, the main differential diagnosis in the renal biopsy is the C3 glomerulopathy, especially C3 glomerulonephritis, which have similar conditions or similar findings, including subepithelial humps and exudation and weak immunoglobulin deposition. So it is the main differential diagnosis. But in the dense deposit disease, it is easy to differentiate by electron microscopy with the electron dense transformations seen in the glomerular basement membrane. What about the natural history? Natural history and prognosis of patients. Again, it is different, like the clinical manifestations, it is different from children, from adults, because children usually have a mild affection, and there is usually spontaneous recovery and increased urine output by 1 week, and resolution of other clinical symptoms and serological tests within 1 month. So usually there is spontaneous recovery, and in the stage renal disease is only occurs in less than 1% of children. But it is also important to know and reassure the patients and their relatives and parents that there might be persistent mild proteinuria and microscopic hematuria that might persist for 1 year without affecting the prognosis. So you need to reassure the parents about having some persistent of this proteinuria and hematuria which can occur. What about adults? Adults are usually much more risky and have higher acute complications and persistent renal impairment in 30 to 70% of patients, especially patients with nephrotic range proteinuria and congestive heart failure in 40%, and slight more high mortality. Nephrotic presentations and persistent proteinuria are in adults are associated with worse long-term prognosis. Don't forget that nephrotic presentation of post-streptococcal in adults is poor prognostic feature. Is a poor prognostic feature. So children usually have a much milder disease, while adults having much more complications. What about the treatment? Management include treatment treatment of this infection, of this streptococcal infection, and early antibiotic treatment is likely to prevent this post-streptococcal glomerulonephritis. As we said early, that the early antibiotic administration nowadays decreased the incidence of such conditions, and it is usually these streptococcal infections are usually treated by oral penicillin and intramuscular penicillins, and we can use erythromycin in patients allergic to penicillin, or we can use cephalosporin or cephalosporin. Treatment for the acute nephritic syndrome or the acute nephritic presentation, it includes fluid and sodium restriction, administration, of course, of loop diuretics for this volume overload and congestion, and we can give calcium channel blockers for this hypertension. We can need hemodialysis or dialysis in around 25 to 30% of adults, but it is very rare to need dialysis in children. To summarize our talk today, post-streptococcal glomerulonephritis is a prototype or an important example of the immune complex mediated glomerular injury, usually occur in children. Classically, it occurs following skin or throat infections 10 to 20 days. It includes pathophysiology is following streptococcal infections, especially the nephrogenic strains and the nephrogenic antigens, especially the nephritis-associated plasmin receptors and streptococcal exotoxin B. The main clinical presentation in children is typical nephritic presentation, while in adults have a much more higher incidence to can have nephritic, but can have nephrotic presentation in 20% and congestive heart failure. In the renal biopsy, when needed, when the diagnosis is not confirmed, by light microscopy it shows a diffuse proliferative pattern. By immunofluorescence, we have typical C3 deposition, complement 3, and the IgG deposition. In electron microscopy, we have subepithelial humps. Don't forget that. Usually, the prognosis is very good in children and spontaneous recovery by 1 week or 1 month. But in adults, we can have much more higher complications, and treatment include to treat this infection very well. And in nephritic presentations, we might need loop diuretics for volume overload and calcium channel blockers for this hypertension. This is our sources. Thank you، وعيد سعيد على الجميع إن شاء الله. شكرا.